going on here, I'm going to show you on the right-hand knee because I've got a right-hand model. This is obviously a knee joint. This is the outside here, outside, and the inside. I'm going to take the kneecap away. You've got the bottom bone, you've got the top bone, you've got the blue stuff, which is the meniscus in between. Don't worry about the ligament. You also then have a kneecap that sits on the front. The kneecap, when you bend your knee, goes up and down and it articulates with the back of the knee. We've gone through and assessed all the different things in your knee, and the most likely thing that's going on here is you haven't hurt the meniscus, you most likely haven't hurt the joint, but you've got an irritation around the kneecap. And even when you would have put your finger on the pain, it just feels around this sort of area. So this is what we term chondromalacia patella, or CMP, or patellofemoral pain. And as we said in the letter back to the doctor, oftentimes what can happen is it sort of sits in this there's a little groove it sits in, and it can sometimes just come out of that groove and either onto that side, or you can just get an irritation. Most likely what happened for you is you just increased the load too much. You went from a heavy, like a 15k run, and then what you would have done, and interestingly, when you increase from 10 to 15, if we looked at your running and look at the data, we generally probably find that that last 5k, you would have probably been stretching yourself a bit, and what you tend to do is increase your stride length. So you maintain your velocity by increasing the stride length, and then increase stride length, so bigger steps just puts a bit more pressure on your knee, and it tends to produce a lot of pressure behind the kneecap, and then follow it up with the hard ride, and it's irritated behind the kneecap. Generally speaking, cycling's not too bad for these. It's just a combination of the two. That's why at the moment we're saying probably just give it a break from the running. I'm saying 4 to 6 weeks from the running aspect of it. We'll get you back without too many problems. More probably like the 6 week, and then on to the pre-jumping and then interval running. And what you'll find when we're going to get you through a basic lower limb strengthening program. What you'll find is then at about 6 weeks we do pre-jumping, which is in a bit of jumping, readiness for interval running, and then you find by that stage it won't be painful, it'll feel better. Continue the anti-inflammatory to get rid of the inflammation, so he used the full course of that. Interesting, a lot of physios and docs will get you doing as part of your rehab to strengthen the quad, lunges and squats. They're completely the wrong thing to do. And so what we do know is this is looking at the compressive force behind the kneecap. We know that if you go into a squat or a lunge for a 70 kilogram male, it's about 5,000 newtons of force behind, 15,000 interesting in a full squat position. The take home message is squats and lunges are the worst thing you can possibly do for the rehabilitation. But if you went online or you speak to 9 out of 10 physios, they'll tell you to do those things, and in fact it will make it worse. Step ups, step downs, etc. the worst thing. We're going to show you obviously leg press, high load, small range. It's the most important exercise. Do you have access to a leg press? No, so we'll talk you through here. We've got one here. Patients oftentimes will come for a bit of treatment, they'll come and use this, but we don't charge them, just come and use it. You just have to do it, because the leg press is particularly important because we can do very high load, small movement. And the bottom line is, when rehabilitating knees, you can do high load up to a ton, so it doesn't really matter. Small range, it's not going to hurt the kneecap. So it's the range that makes a difference. Calf strengthening is particularly important. Glute strengthening, a whole lot of different reasons. It's physio to move the kneecap and also increase the quad length. And we do those sort of things, and then by 4 weeks we can start on a pre-jumping program. But essentially today, it's a patellofemoral kneecap issue. Is it worth MRIing it? Is it worth doing a plain X-ray? Not particularly. If we were to find an irritation behind the kneecap, we're still going to treat it the same way. Anytime we're going to send you off for an X-ray or even an MRI, would be it's going to change our treatment course. And that's not going to whatever we find, it's not going to change. In a small percentage of cases, if you got to 6 weeks and it was going nowhere, we may do an MRI just to help us understand why it's being a bit recalcitrant, a little bit slow. And sometimes we might find that you've just got a bit of wearing out behind the kneecap through the cartilage, and it helps us understand why we just have to double the time. It's just going to take longer. So we do it for that reason. We can do a plain X-ray to show us that you have a high sitting, what we call a patella alta, high sitting kneecap, and a shallow trochlear groove, so it moves in. That's an academic thing. We're still going to treat it the same way, and most likely for people, especially women with patellofemoral pain, they tend to have this patella alta and also the high sitting, and also the trochlear groove dysplasia or the shallow trochlear groove. So they're academic questions that we can answer with X-rays and MRIs, but it's going to change our treatment course. As I said before, braces, taping, acupuncture, lubricant injections, glucosamine, things, stem cell injections, PRP, give you the gamut of stuff. these things are pretty ineffectual, don't seem to make much sense, and we don't tend to advocate those, not because we don't do them, because they just don't work. Things like electrophysical agents, ultrasound, tingling, stuff, all these are a waste of time as well. It's pretty simple with this. Mobilisation of the kneecap, an anti-inflammatory and a structure strengthening program. You do that, 80% of these, 85% in 3 months will settle with conservative treatment. That's it.